Good morning, everyone. I'll be presenting on the topic. As we all know that retinopathy of prematurity, it is a retinal vascular disease that usually affects the premature infants in whom the retinal vasculature is not fully developed at the time of birth. It is considered as third epidemic in India and other similar middle income countries, and a global initiative has been taken for elimination of avoidable blindness. The ROP, the trend has been increased because of increased rate of premature births, compromised neonatal care, and lack of screening and treatment programs. For this study, informed consent was taken. There is no financial and sponsorship. There is no conflict of interest, and the aim of the study was to find out the epidemiological changes in retinopathy of prematurity in tertiary care center of Northeast India. It was a prospective observational study which was done in NICU of Guwahati Medical College and Hospital from June 2022 to 2024, which included 1152 infants which were admitted in Department of Neonatology. That fulfilled inclusion and exclusion criteria. Inclusion criteria included all the infants, birth weight of less than 2000 grams, gestational age less than 34 weeks, and infants with age group gestational age of 34 to 36 weeks with comorbidities like apnea of prematurity, prolonged oxygen therapy, cardiorespiratory support, and intraventricular hemorrhage. And the loss to follow-up cases were excluded, and all the infants with weight less than more than 1500 grams and gestational age more than 32 weeks with no history of cardiorespiratory support, ventilation, long duration of oxygen therapy. Detailed maternal history was taken. Initial examination, it was done not more than 4 weeks of the birth, and the pupils of infants, they were dilated using fixed combination of 0.4% of tropigamide and 2.5% of phenylephrine drops. The screening, it was done by trained ophthalmologists at NICU under supervision of pediatrician after instilling 2% proparacaine drops using lid speculum, using binocular indirect ophthalmoscope and 20D lens and a scleral depressor. The babies, they were diagnosed with ROP the baby diagnosed with ROP were classified according to the international classification of ROP, and they were followed up till 40 weeks of postmenstrual age or till retinal maturation was complete. So in our study, we saw that out of 1152, 42% babies, they were born with between age of 30 to 33 weeks. Less than 40% were less than 30 weeks, and 18% were more than 34 weeks. And they were screened. 1152 infants were screened for ROP. They had a birth weight of less than 2500 grams in 37% patients. In 14% patients, less than 1500 grams. In 3%, the birth weight was less than 1000 grams, and 46% they had a birth weight of more than 2500 grams. Also, the associated comorbidities, hyperbilirubinemia, it was seen in 16% of cases. Respiratory distress syndromes, it was seen in 10% of cases, and oxygen supplementation, it was given to 23% of the patients. These all the infants, incidence of ROP in different regions of India across has been reported, the range of 38 to 47%. In our study, stage 1 ROP was seen in 50.5% patients. In stage 2 was seen in 31.9% patients, and in 6% patients, stage 3 was reported, and 2% were presented with stage 4, and 1.5% were presented with stage 5. And aggressive ROP was seen in 6.9% patients. Out of 188 infants who were detected for ROP, out of 188 patients who were detected for ROP, 29 patients, out of 188 infants who were detected for ROP, 71.2% they regressed spontaneously, and 27.6% infants, they were subjected for intravitreal injection, and 2.12% infants, they were referred for vitreoretinal surgery for higher center. And also the infants who received intravitreal injections, they were followed up according to ICROP guidelines, and out of them, 94.3% infants, they showed ROP regression, while 5% infants, they were lost to follow-up. So I would like to conclude by saying that a recent change in Indian guidelines warrants the screening of all infants with a birth weight of less than 2000 grams and gestational age of less than 34 weeks, which should be done within the first 4 weeks of birth with an earlier screening in infants which were born before 28 weeks or lighter babies less than 1200 grams. usually to be done within first 2 to 3 weeks of life. And all the infants which were treated with anti-VEGF injections, they showed regression, and recurrence was not seen in most of the cases, which establishes the role of management of ROP with anti-VEGF injections. And also, due to advent of improvement in quality of neonatal care and expanding ROP screening devices and increasing awareness about the risk factor, there has been early detection of preterm infants and hence decrease in burden of childhood blindness. These are my references. Thank you, ma'am.
Nice presentation, Dr. Garima. Would like to, after seeing the incidences in the Northeast India, so would like to highlight about the screening programming, more of screening for the ROP child.
Yes, ma'am.
Need to mobile screenings that should be happening. So to detect the baby in early stages, to intervene early, and to further preventing that baby going into an 4 and 5 stages. So for that, what we can do is in pediatric setup itself, we need to tell the pediatric or neonatologist to tell the parents properly about the condition of the child, because they don't know the baby outside, it will be in a low weight and they will be more concerned about the weight gain and the general condition of the baby, but they might ignore the eye changes which are happening to the baby. The parents also might not be aware. By the time they are aware of the condition, the baby might have lost her vision as well. And the parents also at that time later on, they might blame the pediatrics, neurologist and the ophthalmologist. So that should be highlighted in the screening thing or else like that, to reduce the burden or incidence.
Yes, ma'am.
Nice presentation.